Good evening. My name is Dr. Sharon Wexler, and I'm the president of the NYU Myers College of Nursing Alumni Association Board. On behalf of the School of Global Public Health and the Rory Myers College of Nursing, it is my honor to welcome you to this special program this evening. Today we'll be talking about how GLP-1 drugs like Ozempic, Wegovy, Zepbound, and Mounjaro have dramatically transformed the medical treatment of obesity. We've heard a lot about the significant weight loss many people experience from the drugs and are just beginning to understand the other ways they might improve health, from heart disease and sleep apnea to kidney disease to substance abuse. But these drugs raise many questions about their side effects, high cost, shortages, long-term safety, and gaps in who has access and who doesn't. So, are these drugs a revolution, risky, or both? We are joined tonight by two experts on obesity who will shed light on what these drugs mean for patients, healthcare, and society more broadly. Dr. Virginia Chang is an associate professor at the NYU School of Global Public Health and NYU Grossman School of Medicine. Dr. Chang is a physician and sociologist whose research largely focuses on obesity and health disparities. Her work engages topics including the influence of social determinants of health on obesity, the relationship of obesity to mortality and disability, and the influence of weight status on the quality of medical care. We also have with us tonight Dr. Angela Godwin, who is a clinical assistant professor at NYU Rory Myers College of Nursing. Angela is a board-certified family nurse practitioner whose scholarly interests include obesity, diabetes management, metabolic syndrome, and health disparities. She runs a private clinic in the Bronx with a focus on weight loss and bariatrics. The discussion will be moderated by Rachel Harrison, Associate Director for Research Communications at NYU. As part of the university's Office of Public Affairs, she focuses on promoting health and science nursing, science research, news, and expertise for NYU's Rory Myers College of Nursing, NYU's School of Global Public Health, College of Dentistry, and Departments of Chemistry and Biology. Please join me in welcoming our panelists this evening. You can submit your questions to the panelists throughout the program. Take a picture of the QR code on the little tent cards that are on your table and enter your question into the Google form. For our virtual guests, you can put your questions in the chat. I will now turn over the program over to our moderators.
Well, thank you, Dr. Wexler, for the introduction, and thanks everyone for being here this evening. We're going to start the evening by setting the stage a little bit, and just look at the state of obesity in the United States. So I'm going to start with you, Dr. Chang. According to the CDC, more than 40% of U.S. adults are obese. What are the factors that have driven this increase in obesity in recent decades?
So, as you just said, 40%, according to the CDC. In 1980, it was 15%, so it's gone up quite a bit since the 80s. And, you know, for most human traits, it's a product of an interaction between genes and environment. And what we can say is our gene pool has not changed in the last few decades, so that, you know, we look to the environment and we can think about food and physical activities. So in terms of food, it is much cheaper to produce and purchase food now than it was in the past. We have the overproduction of from farm subsidies, certain products such as wheat and soy, and we have ultra-processed foods, we have food deserts, all those kinds of things. On the other side, in terms of how our environment is making us less prone to be active, is that we've moved from a service sector society, an industrial labor-based economy to a service sector society. It's everything from suburbanization to cars and highways and just sort of all the ways that activity has been sort of engineered out of our lives. And many people have referred to this as an obesogenic environment. And frankly, as a species, right, we have evolved during multiple periods of famine. And so we have evolved to be very good at storing and maintaining fat. And probably our taste for things that are sweet and fatty has evolved from that perspective as well.
Interesting. So thinking about how obesity has been treated historically, before GLP-1 drugs, which we'll get into shortly, came along, what other options did people have for losing weight and keeping it off, Dr. Godwin?
Good question. So before GLP-1s, the most popular one, which is still around now, which you might have heard, is called phentermine. And that's a pill, it's a stimulant. Phentermetrazine's along with that. Adipex is the other name, and it makes you just feel like not eating. And that's all it really is a stimulant. People have also in the past and still used metformin, which is more so known as a drug for diabetes, which helps with glucose. And then other common methods were like laxatives and diuretics and so forth. But the real one that's out still is phentermine, almost like fen-phen, which was outlawed a while ago. But same kind of effects where it pushes your metabolism.
And then certainly bariatric surgery, which I know is part of the work that you do, is another area that has offered a treatment solution, but maybe isn't for everyone.
It's been found to be effective. It's still considered the most effective treatment for obesity and morbid obesity. It's not for everyone. A lot of my patients do fear having surgery. It is not it's not something to take lightly, but not everyone qualifies for it, and not all insurances pay for it either. And there are just other concerns in that as well. And people who get surgery gain weight back too, and that's a population I also see. So it doesn't solve everything.
So it sounds like there's been a longstanding gap in how to help people who are struggling with weight. And that's where this class of drugs that we're going to be talking about comes in. Dr. Chang, can you just give us kind of a primer? What are GLP-1 agonists and how do they work in our bodies?
And so GLP stands for glucagon-like peptide. And what it does is that it stimulates insulin. And so it makes people feel fuller for longer and faster, right? So it affects the speed of food going through locally, but there's also central effects. So it also affects the appetite centers of the brain, where it can curb hunger and cravings for food. And people have also described that it abates food noise, right? Which is this tendency to ruminate on food. So if you want to get into the weeds a little bit, semaglutide is the active ingredient for Ozempic, which everybody knows, and Wegovy. And then tirzepatide is the active ingredient for, Ozempic is from Novo Nordisk, and then Eli Lilly has their own version with tirzepatide, which is Mounjaro and Zepbound for obesity. Mounjaro is for diabetes, Ozempic is for diabetes. And that particular drug is potentially a little more effective because not only does it affect GLP-1, it also affects GIP, gastric inhibitory peptide. So it has two mechanisms of action.
And what does it look like in the clinic, Dr. Godwin, when these drugs are prescribed to people? What are their how are they given, and what are their experiences of taking them? What are some of the side effects they might be dealing with?
So the semaglutide and tirzepatide are the more recent used for weight loss, and they are once-a-week injections. There's an older medication called Saxenda. It's still around. That was daily, and people didn't tend to like that as much. So this is a once-a-week injection. The number one side effect is nausea, which I would say a good amount of experience in the beginning. It's tolerable. People do ask me for Zofran. I'm like, it's not that bad where you're going to be vomiting. But as Dr. Chang was saying, it also causes constipation because that's part of how it works. Gastroparesis slows gastric emptying, so constipation does happen. Acid reflux because the stomach is empty, still producing acid, especially if people are skipping meals, which because of the food noise is now gone, people are like, oh yeah, food. And their stomach's empty, and then acid is coming up. And then some fatigue is something else that I hear about as well. But I would say nausea is probably the number one side effect. And then just telling patients that they have to eat slow, because of that slow gastric emptying, their stomachs get full faster. So they're used to eating like this amount, and then they eat like 3 bites in, and they're like, no, their mind tells you to eat more. Well, your stomach is already full. So that also can perpetuate the nausea.
seems like there's some relearning that happens
A lot of
in the
training.
process. So many of us in the room have probably seen on our social media feeds and in signs in the subway, lots of ads for these drugs. We're getting targeted with WW or Weight Watchers Direct or Noom or Lilly Direct or these compounded pharmacies that are bringing these drugs to our feeds and then potentially to our doorsteps. I'm curious to get both of your thoughts about how telehealth and this direct-to-consumer marketing, especially through social media, are changing how people are getting these drugs, and then what does it mean for the clinical interactions? I'll start with you, Dr. Godwin.
It was so funny you said that because I was just watching something last night and Hers came on, and that was just all in my face and came on like every 2 seconds, Hers. And I was like, what is this? And that's another example of how it is. It's on, and patients tell me that they saw it on TikTok, they see it on YouTube. And so what's happening is that people are bypassing the clinician. In some ways, because they're getting it through this telehealth. And a lot of it is compounding, which we could talk also about that and the
could you
implications.
briefly explain what compounded drugs are and what that might be?
So compounding is the creation of medications which are thought to be outside of that FDA regulation. So FDA, of course, approved Zepbound and Wegovy and Mounjaro and so forth. Compounding versions are not the exact organic makeup of those meds, but it is considered the same type of semaglutide, the same way you have acetaminophen and Tylenol. Acetaminophen is the compound of Tylenol. There are some concerns because how it's compounded is not FDA regulated. So you have these pharmacies now creating semaglutide usually they compound it with other things like B12 and other vitamins to make up the medication, which then can affect some of the side effects, the efficiency of how a patient feels on it. And there are some concerns because of the lack of regulation. But because of that, it's cheaper. Patients tend, of course, people like things that are cheaper, but then there's less regulation for it. So you're seeing people with even more side effects and taking more of the medication than they should. And because it's so marketed well, people tend to think that it's much more easily available to them, and that causes more problems in that way.
And Dr. Chang, curious to hear kind of from a sociological perspective, like what does it mean if we are bypassing this traditional doctor-patient relationship?
I mean, I'll answer that, but I will also add that nobody seems to know where they're getting the semaglutide or the active ingredient. So that's one thing. The compounding pharmacies are FDA regulated, but the drugs are not regulated. And this thing is, it's like the wild, wild west. Once you click on one of these things on Instagram, they will just send you ads nonstop, as I get on my phone now because I clicked on one. But it's... to meet demand, right? So there's these online things. Some of them are providers, some of them aren't. More, I think there's a huge variation in quality. But some of them are being provided by Weight Watchers or Eli Lilly are having their own telehealth versions, right? So where you're not getting a compounded version, you're getting the actual drug. But this is in a setting where you're going to see a doctor in pursuit of one thing and one drug. So it is no longer sort of a holistic encounter with a provider where they're evaluating you and all of your history and your conditions as a whole. So I think nobody knows. And I think people are also, because when you get it from a compounded pharmacy, it comes in a vial and you have to mix it yourself, right? And so when you get these actual drugs, they come in preloaded pens, and so people don't necessarily get the dosing right. They have to keep things sterile. There's like all kinds of problems. I will add one other little anecdote. I sat down with CNBC to do a documentary on this drug last year, and the producers, for fun, went online and tried to get one of these drugs. And so the host of the show answered 5 questions, and next thing you know, the drug arrived in the mail. And, so it's like very unregulated.
So I was going to say, yeah, with these vials patients get, they're just told to take so many units, and they have to draw it up themselves. And I know that there are patients who they want to double it up because they somehow, people think the more meds, more weight loss. So that doesn't work exactly that way. So people are then doubling up on their own, because they can. And it's a problem.
I mean, in your training as clinicians, like all the things that you're taught to do to interact with patients and to evaluate them? Are these all going out the window in something like this?
Well, something I was going to add to what you said, it's not holistic, and that's what really bothers. It's just being a nurse, like that's what we do. We're holistic in our care. And so when we're looking at a patient, it's not just about like, oh, you want to lose weight. It's, well, how are you eating? Are you sleeping at night? You know, what's your job schedule like? Do you eat when you're at work? And then I also do a full panel. What's your thyroid like? Are you anemic? Like, there's so many other questions to ask, and I think people see this medication as the end all, and they're not addressing those other issues that need to be addressed. And I explain that, you know, the medication's great, but it's meant to be a tool, and everything else also has to come together. And I think because that conversation is not fully happening now because of how easy it is, a lot of that's being lost.
So one of the reasons that these compounded versions became so prevalent and popular has to do with shortages and drug companies not being able to keep up with it. There have been these shortages. There's also concerns about high price tags of these drugs. Curious to hear from both of you about whether you think the drugs are actually reaching those who most need them from a medical perspective, perhaps from a socioeconomic perspective. Dr. Chang, I'll start with you.
The answer is yes and no. So there was an interesting study here in New York City about a year ago where they looked at pharmacy fills. And it turns out the highest per capita pharmacy fills in New York City is on the Upper East Side of these drugs, where diabetes and obesity are the lowest. And so, no, these drugs are not necessarily going to where they need to be. They're going to where people can afford them. But they also are, I mean, they're originally designed for diabetes. So they are also going to places where there's a lot of diabetes. And so, yes, and there's huge problems with shortages and affordability, and we can go into that, like what's going on with Medicare and the negotiation with Medicare and all that. And I can also get into what it's doing for disparities, but I think that's a different question.
I'm curious, Dr. Godwin, to hear about the coverage piece of it and whether that is.
And then I want to get back to the disparities parts. Okay, so insurance, that's majority of what I literally have hired nurses just to deal with insurance companies. So if you have an insurance that pays for it, great. Just to give some background, medications like this, Mounjaro, Zepbound, for the month, for a box of 4 pens, is about $1,200 for the month. There's a coupon. Last time I checked online, it was $650 per month. I don't know who can afford that. Like, without planning, I guess. Like, I guess if you consider it like another car payment, I don't know. Maybe you can afford it. So the fact that $650, right off the bat. So if you have an insurance that will pay for it, great. I can write off, some of them who do. And there are a lot of employers now who are covering it. So it's almost becoming like, were you looking for an employer to cover like your IVF? Like that was the big thing. Now it's like, oh, who's going to cover weight loss medication? A lot of hospitals now are, Disney, JP Morgan, so you can figure out how that's going to work. Unfortunately, and I think this is going to your point, Medicare, Medicaid is not covering this, right? And then we're in New York, so let me just say it, DOE, Department of Education, not covering it. NYPD, not covering it. Department of Corrections. And so I already know if someone comes in, I ask like, oh, who's your, which I hate asking patients, like, who's your insurance? Like, because it sort of sounds so monetary, but I have to know because I need, what's the plan if this is what you want? And their answer is, oh, I work for the DOE or I have this insurance. I'm like, oh, well, then you have no options, pretty much, right? Like, or you pay for it out of pocket. And then you get to the other side, which is what you're referring to, which, well, then if you are paying out of pocket, who's able to afford that? And what you're finding are that the patients who do have the sleep apnea, the diabetes and hypertension, all that, are the ones who have those jobs that aren't paying for it and then can't afford the cash, which is the $650 a month. So it's a difficult place to be. And that's when compounds then become more of that option, unfortunately.
Is there any catching up that's happening as there have been more and more FDA approvals for different indications for the drugs? Are they becoming more covered for those who need them?
So in December, Zepbound was finally FDA approved for sleep apnea. And Medicaid will now cover, and Medicare, if you've had a cardiac event, they will cover Wegovy. But they are very strict as to what they identify as a cardiac event, because I have patients who come with hypertension, high cholesterol, and that is not enough, unfortunately. They actually want you to have had like a heart attack, and it's so sad to say that, or to have a stroke, or to have a stent placement, or something like that to get it paid for. I've had arguments on the phone with medical directors. Like I had a patient with an A1C of 6.4. So diabetes is 6.5 and higher. They were 6.4, wouldn't get it covered. It's 6.4. Like what are you waiting for? And just didn't happen.
So, on the coverage issue, these drugs were on the list with the Biden administration to get Medicare to not only cover it outside of cardiovascular risk, right, just for obesity, but also to negotiate the price. And so we don't know what's going to happen with the incoming administration. We don't know if RFK Jr. becomes the head of Health and Human Services, what his take on all this will be. So I think we were approaching potentially increasing coverage, but we don't know where that's going.
And it sounds like some of it might be the federal government playing a role in negotiating these prices down, but time will tell.
It has to be, right? We cannot, given 40% of the population is obese, right? These drugs are so expensive right now, I don't know how we would cover 40% of the population to be on these drugs, right? The price will gonna have to come down. The patents run out in 2032, right? There's going to be competition. Other companies are going to come up with their own version. There's going to be an oral pill available at some point. And so the cost thing it's not sustainable at the moment in its current iteration.
I'm going to jump ahead to a question I had about the cost. So we know these drugs are really expensive, but we also know that health conditions and managing chronic disease is also really expensive. I know you've looked at some of the data and some of the calculations about whether prescribing these drugs can offset the costs. Where do things stand now? And maybe where would you like them to be?
I would say nobody knows. And I know people like to make predictions and projections, including me. But there's two reasons for that. One, we don't know the full extent of how we're going to use these drugs, right? Every time I turn around, there's a new application. It's almost like, should we just put it in the water, right? It's cardiovascular disease, obesity, it's chronic renal disease now, it's Alzheimer's, it's alcohol use disorder, it's, all kinds of compulsion, smoking, gambling, and especially if it starts getting used for Alzheimer's disease, that's a big, right, population. And so we don't know, because we don't know the full application, we don't know the full extent of its benefits, right? To know the cost savings, we have to know its benefits. But we also don't, as I was saying before, we also don't know where the costs of these drugs are going. I would predict that over the short, medium term, and for sure in the longer term, the costs of these drugs will come down.
What I don't understand, and maybe you can help me in this. I have a patient who went to Ghana and she came back with like 4 pens of Ozempic because it's so cheap over there. And my understanding is other countries have it much cheaper. And eventually, like I said, I think we have to meet that because we have such, 40% compared to other countries. Doesn't make sense. And then for it to cost so much, it's not fair in some of those ways.
So kind of building on what we've been talking about, does seem like every time you turn on the news or open a paper, there's some news about these drugs, and especially new indications for them. Just last week, the FDA approved Ozempic for treating kidney disease in people with diabetes. And it feels like there's a new study every week about some new, way that these drugs can be used. Curious to hear from both of you what you think are potentially the most interesting or promising applications, and just kind of building on what you were just saying.
I think Alzheimer's, like you said, that to me, I think is the most interesting.
But yeah, the evidence on that is very
it's just started,
preliminary, right? And why?
But it makes sense with the GLP receptors.
Some of it is because it helps with obesity and diabetes, which are risk factors for Alzheimer's. It also, insulin functioning affects the brain. It could also have like even more direct effects on the brain in terms of tau protein. And so we just don't know. Right now, they don't even cross the blood-brain barrier that well. And so, but there's going to be other iterations coming. I mean, believe me, every pharmaceutical company is doing research on their version for whatever application. So,
any other applications besides obesity, heart disease and diabetes that have kind of more evidence at this point that seem like really solid ways to use these drugs to prevent disease?
So one thing I want to add in, just because I use it a lot, and it's not really considered, is because GLP-1s, I always explain to patients, it really affects how much you can eat, and it does sort of shut off the food noise. But especially, I don't know, I have to look at the cultural aspect of this, and you can let me know, Dr. Hank, if how much emotion plays a role in our eating, especially since I think COVID, there's been a lot of just emotion that we're dealing with in regard, like just eating out of anxiety or depression. And so there's another medication which we don't really talk about much called Contrave, which I think also helps. It's another part of that conversation because there's that factor of the emotion, the addiction almost of eating that I think also needs to be addressed. So Contrave actually has Wellbutrin in it, which it works like as an antidepressant. And I think these GLP-1s, because of the effects that they have on the brain, will also work well for that emotional, addictive process that we go through.
Interesting. All right. So thinking about kind of this big picture society level, when we look at these new weight loss drugs, do you think, Dr. Cheng, they're starting to shift cultural norms and stigma around obesity at this point, or could they do this in the future?
The answer is definitely, right? So obesity, it's long been this back and forth around accountability, right? Is it just a matter of personal decisions and personal behavior, or is it behaviors being, structured by an environment that is, so strong that the person hardly has any agency? It's a sort of old structure-agency debate in sociology. But with these drugs that are so effective, and they really are so effective, right, that can curb the behavior, you've kind of put that whole argument, flipped it on its head. So if suddenly the behavior is quite easy to control, on the one hand, you can sort of remove some stigma or shaming around failure to lose weight, right? But on the other hand, you can also create more pressure around people to do so, right? There are now plus-size influencers all over Instagram that are now on the drug and promoting the drugs for these companies when they used to be promoting, plus-size, body positivity, that kind of stuff. What else was I going to say? I can't remember right now.
The fact you said that, there was an actor recently I saw who has gained weight, and I found that interesting because I think people are into not like almost against jumping on the bandwagon, like and being like loving themselves and not needing these medications. And I do wonder where that's going to go if they think like, well, anyone can get these medications. Eventually, if anyone can get it, anyone can do it. Then where is the line to say, oh, like everyone should be on it, or obesity? Do we almost like how we got rid of polio? Like, is that like a thing for weight like obese? I don't know, like where that's going to go.
Right now, there still is sometimes people are like, oh, well, it's just a cop out if you take this drug instead of doing it the old-fashioned way. But also, when there's a trait in the human population, and the more common it comes, it can become less stigmatized over time, right? Something just becomes more common. So if obesity becomes less and less common, will stigma actually go the other way? Will become more stigmatized over time? And so I think, it's really changing a lot in terms of social norms around bodies and accountability.
So part of that made me think, though, is that these medications are long-term. So where the cost is going to go long-term with that, when I say long-term, I have patients who reach their goal, they're like, I don't want this meds anymore. I'm like, great. So that means you're going to have to, go keep focusing on your eating and exercising and even up the exercising even more. And unfortunately, the majority of them do come back with regained weight. And so then it becomes a conversation of, well, what does this look like now? Because you know that you need this med chronically. And they do the injections maybe like every other week or something like that to keep up with it. I'm curious to see where this goes. Like, are you going to be doing injections every other week for the rest of your life? Like in 5 years, 10 years, what is that going to look like?
And so it does seem like it is something that is not a short-term fix. It is a long-term lifestyle change and medication option.
And it also doesn't work. Like, there are patients who are on the semaglutide tirzepatide trying to dosing change, and they're just not losing also. So it's not as if, coming out, I don't want to make think like, oh, everyone could be on this and everyone's going to lose weight. There are definitely contraindications, like thyroid cancer, medullary, those issues there where someone can't be on one of these medications. There's, of course, the financial aspect of it, and then it's just some patients, there's other factors that we need to consider where it's not 100%.
Is it side effects that usually make people want to come off them, or they just don't necessarily work for some people?
In my experience, it works. So put things into perspective. Healthy weight loss is considered 1 pound a week, 1 to 2. These medications, with some studies, have found that it's almost simulating like gastric bypass with the type of weight loss that we're seeing. Where that goes, for patients, and how much is it affecting every patient? My oldest patient's 89 years old. She's 30 pounds down. You would think, people are like, oh, why does she care? Well, no, when I'm 90 I'm still going to care about how, and I tell my staff that. So does it work? Yes. Does it work at the rate people want? Do people still want to eat the way they want? So part of that, again, like there's so many other things that you have to fix, and it's not just the medication.
So this brings me to a good segue to the next question. In the beginning of our conversation, we were talking about factors that are driving obesity, things like ultra-processed foods, having less active lifestyles. Where do these drugs fit in the mix with all of those other factors? Do you think these drugs are actually getting at the root causes of obesity, or is it a square peg in a round hole and it's helping, but it's not addressing the underlying problems?
I mean, the answer is no. It's a quick fix, right? We're not addressing any of the social, political, historical, structural aspects that got us here to begin with. So you might say, well, then we're just, using medications to fix a thing that has these larger problems. Now, that being said, we have been trying to fix those larger problems from a policy and public health standpoint for many decades, and it has not been able to curb obesity. And so, yes, it's a drug, it's effective, you do have to take it lifelong, but from a cardiovascular disease standpoint, it's not that different. Well, it is an injection, but it's not that different than taking a hypertensive medication forever, or taking statin forever for your cholesterol. But it does mean that we've decided to, chronically medicate people for a problem that does have all these social causes, right? I'm always reminded of a quote. I can't get the quote right, but it's sort of like, it's from Tressa McMillan Cotton, in probably a New York Times op-ed, said that, we're really good at solving social problems by fixing individual bodies and creating consumer demand to fix those social problems.
And because these drugs are so effective individually, does that make us lose sight of those social problems? How is this going, Dr. Godwin, in your practice, in conversations with people about eating more healthfully and changing behaviors? Is that still a major challenge?
So I think we initially started talking about like the telehealth, and I think that's a major part that's lost. But because people go there, they get this medication, again, they're thinking, oh, that's it. And there isn't that larger conversation about the diet and the need to change. And, you could be skinny and still have high cholesterol. You could still have a stroke. You could still have hypertension. So ultimately, are my patients, some of them do get it, and they realize that this is just, and just to help get to that end goal of being healthy. But, my office, my main clinic is in the Bronx, and, food deserts is a thing still. Can I expect them to still eat like the way I prefer, with high protein and lots of vegetables and fruit? Like, how is that available to them? Or, I think of all the bodegas and fast food in the area. What is easier? And those things have to change, or people have to make more of an effort, a difficult, decision to where their money's going to go and how they spend their time and in cooking to be healthier. And those injections aren't doing, that's not going to solve that issue. So,
I mean, there's also this existing disparities issue, right? So obesity, diabetes, and all of their downstream consequences have social gradients right now, strong social gradients by education, by income. And given the unequal access to these drugs, they are inevitably going to make those gradients worse, right? Or at least initially. I mean, it's, we've done some work on it. The story of cholesterol is an interesting example. So cholesterol, like obesity, used to be really hard to treat with existing drugs or with lifestyle modifications. And then they came out with statins in the 90s, which were really effective. And so before statins, higher income people used to have higher cholesterol because they ate more meat and they ate more eggs and they had worse cholesterol. Once statins came out, that gradient completely flipped. We created a new disparity where we didn't have one before, where suddenly higher income people had the lowest cholesterol. But you know what? Everybody's cholesterol came down, right? Over time, on average. So it's kind of like a high tide lifts all boats. So that could happen in this case as well.
So I'm going to ask you to put on your forward-thinking caps and think about what you'll be looking for as academics, as clinicians, looking at these drugs in the next 5 or 10 years, what research you're going to be looking for, what you're going to be looking for in your patient populations. What do you want to see?
I think that goes back to the point of there still needs to be societal change. There still needs to be considerations regarding just overall health and eating, and we can't lose sight of that. So even where this medication ends up going, overall, holistically, we still need to look at the person and how that is. And if the medication does make them, skinny or whatever weight they want, still needing that education, that long-term planning for them, and the ability to have that longevity and quality of life the way that it should be.
How about you, Dr. Chang?
I think I want to know where the most effective applications are going to be, right? Is this really going to work for cognition? I want to know where the costs are going. And I want to know where the longer-term side effects are going. We don't have, Ozempic's been around for diabetes since 2017, Wegovy since 2021, but we don't have any 20-year data on what happens if you take these drugs for 20 years. So I want to know that. But I will also add that, I don't want to just lump this in with other drugs we use to treat cardiovascular disease. There's one, in my mind, really important difference. A lot of the demand is driven by aesthetic reasons. People want to lose weight because they want to look different. Nobody can feel their cholesterol or see their hypertension. So that's one big difference here.
Do you think some of the short-term promising changes we've seen so far, or I'm curious if you think they're promising, we've heard about the food industry, for instance, starting to change some of its formulations and packaging and, offering healthy options for people who are taking these drugs. Do you think that's a good sign, or do you think that's more of the quick fix kind of solution?
Interestingly, these drugs make people lose, they don't think processed food tastes that good anymore, right? They think, fresh fruits and vegetables taste better. It's really interesting. Nobody knows why. And so, of course, the food industry is reacting, and they're coming up with, formulations that are going to taste better for people on Ozempic. So I never think that's probably not a good thing, but they're not in it. They're not just sitting back, and they're not doing a wait and see thing. They are very proactively protecting their market interests.
Yeah, I'm not seeing them let's make more fruits and vegetables. I don't see that happening, no. But it's true, patients they're eating healthier, which is great. Yeah.
Well, that brings us to the end of our questions. So I'm going to turn it over to my colleague, Sarah, who is going to start taking questions from the audience. As a reminder, if those of you here in the room have questions, there's a QR code on your table. Take a picture, send it into the form, and it'll head to Sarah. And those watching on Zoom can enter questions there as well.
Great, thank you. Well, we have lots of questions about long-term negative side effects, which you already sort of answered, but are there any current studies that are looking at this long-term? And also we have a lot of questions about these drugs and their impact on young people taking them, and if there's any implication for family planning or, any complications that you can think of for, future pregnancies?
So long-term, no, just like we said, because it hasn't really been anything. Right now, the ones we know about would be like nausea and just the more immediate side effects. There was a concern a few months ago regarding intestinal paralysis, but what I find in that is it's patients who are overdosing, really. It wasn't really related if they were taking the medication the way it's meant to be taken. In regards to age, the youngest FDA approved is 12 years old. And I have a few 12-year-olds, teenagers, and it's been effective. But same thing, though, it has to be holistic. I've seen it very effective for children, but when children come in, I make the parents come in, and I make both parents come in because it's a conversation about what the child is eating, how they're getting. How does this 12-year-old gets a Frappuccino every morning? Come on, how much is that? So when I start seeing that, I'm like, well, who's paying for this, and how are they eating? And it's a whole conversation with the family. So I do find it to be effective for adolescents. But again, that's that other picture of what else is happening in the home. In regards to family planning, I love these medications for women who have PCOS. It's amazing. It brings helps with A1C levels so in PCOS, polycystic ovarian syndrome, women tend to have high testosterone and insulin resistance, which then causes their ovulation to be irregular, so getting pregnant is more difficult. And these medications have been a game changer. It's really helped regulate that, bring the weight down, cause ovulation to be more predictable. And we have a few of our Ozempic babies, which I love having pictures, and they come into the office. And so actually, I think it's been amazing for fertility, which we didn't really address, but I think it's been awesome.
That's fascinating. And do they stay on the medications during pregnancy? Do they return to them after pregnancy?
No, so we get them down to a goal weight. They go off, multiply, and then when they're ready, they come back if they need to, and we just start when they're done breastfeeding. Yeah.
Fascinating.
Mm-hmm.
I mean, I will add that clinical trials don't go on for 20 years, right? They don't. They do their, couple-year thing and they're done. And so I think what we really don't know is what happens when people take these drugs outside of the context of diabetes, when they're taking them without diabetes or without any cardiovascular risk factors, just for weight loss. I think that's a big unknown.
Because a lot of the studies, there was one that we were talking about last week, was from a VA population, and they all had diabetes. And so it was a large data set, and it was going back a handful of years, but it's still mostly men in the VA, older, and with diabetes. So it sounds like there's still a lot more data that need to be collected and kind of followed over the years.
Yeah.
Great. We have another question about what types of regulations do you believe should be implemented to make these medications more effective and safer? I think specifically maybe the online retailers you mentioned. Are there any policy recourses or any ideas about how to make that safer for patients that aren't coming to your clinic? Or
Well, I think the point you made, the difference is if you were to get the brand, it is pre-medicated. You can't change that, right? So a 0.25 Wegovy is in one pen. You give it, you can't control how much of it, you just give it, and that's it. You throw the pen away. These compounding, like you said, it's a vial. You pull up as much as you want. And I think that's probably the biggest problem I have because patients are really self-medicating and there's no regulation how much. Because I would think a compounding pharmacy could probably pre-fill, probably just going to cost them more, so they might not be interested. But I think that would make a huge difference in regards to like the negative side effects that we see.
And
I don't know anything about government regulation, and so yeah, I do think it's bad. There's bad things happening. I don't know how the law would operate to regulate that.
I mean, the U.S. is a very unique country in terms of direct-to-consumer marketing of pharmaceuticals. It's not something we see in many other countries. So it would be interesting to think about, should these drugs be marketed directly to people in the same way, or should they be relying on the provider relationship?
I mean, it has dawned on me also from an environmental perspective that these injectable pens that people, if everybody's on one of these things once a week, that's a huge amount of
Oh my God,
plastic.
I hate the plastic. Yes, it's true. You're right. Like if every person has 4, and it's not like a Monjaro pen is like this long of just plastic, and it's thick, hard plastic. That I'm like, can we recycle this? Like I'm always thinking like that, and that's a whole nother environmental conversation. But if there's some way, like you said, in other countries, right? You can't just come up to your provider and be like, I want this medication. And here we want what we want when we want it, and we want it now, and prescribe it for me. And that's what apparently I'm here for. So, having that conversation and be like, well, this is not actually a good option for you. Or, other things that we need to consider. If there are some patients you could tell, like once you start talking about their diet, they're like out the door, right? So how do you regulate that? I have no idea.
Well, I'm going to add pen recycling programs to our things that we're watching in the next 5 to 10 years.
And we have a few questions about when you stop the medications, other than gaining weight back, are there any other side effects that you've noticed?
Just everything that comes with that. So the food noise, the pain on the knees. Like, so patients, when they lose weight, all the benefits that they had just sort of all, in some ways, unfortunately, reverse themselves. So the ones I hear mostly about are the ortho pains, honestly. The hypertension, I've had a lot of patients who get the hypertension back with the weight gain. So it's really just the fact that the weight came back. So what does that mean, for the rest of your body, the 30 pounds that you're carrying again? And some research shows that that's worse. That recidivism actually worsens the health of a person when they gain after they've lost it. So, I think that's something else to consider.
Do many people end up even above their baseline weight?
So patients will lose 20, they disappear for a year, and they come back with 40 over. Like, they don't just go back to that number. There's a whole other study that can be done that they gain more.
Okay. And I think just kind of going back, I think there are a couple questions just people are curious about. If you have this data, what percentage of patients are these drugs successful for? How long does it take to work, whatever work means? So I think folks just want a little bit more intel on the initial process.
So like Dr. Chang said, it does not take long to get them. So I usually say within 24 hours of you taking the injection, you feel it working. You feel it change in how you eat. You feel like you could tell you're not thinking about food as much. So I always tell patients within 24 hours you're going to feel it working. In my office, I say we aim for about 10 pounds a month. Again, healthy weight loss is considered 1 pound a week or so. 2 pounds is considered rapid weight loss. 3 that's pushing it. And then again, depending on how the person, the metabolism, young men, of course, lose faster than older women. So those are just some of the considerations there. And then nausea can happen, again, very early on once you first start.
And I believe in the clinical trials, people lost 15% of their body weight and up to 20% with tirzepatide.
Thank you. And Dr. Chang, this might be a question for you, but somebody asked, how is the definition of obesity changing, if at all, because of these drugs?
The definition of obesity has not changed because of these drugs. I know there is a lot of controversy out there about using body mass index to measure obesity, and that's a whole other conversation. I'm still a big supporter of body mass index.
All right, well, we're gonna have a discussion then, because
Okay.
Because I like waist circumference and fat percentages. Oh, we're gonna talk about that after this. Okay.
Oh, well, so body mass index, do we really? Okay.
Well, no, not right
body
now.
mass
I meant
index,
later.
right, does not measure fat content, right? It's a height and weight ratio. And so somebody can have a high BMI if they just happen to be very muscular. And so it can, get the percentage of fat wrong if that's really what we're trying to measure. And historically, body mass index also has some social issues. But for research purposes, it is still the fastest, quickest, cheapest thing we can measure in data. And it is hyper-correlated to all these other measures. And I don't think the other measures have been superior to body mass index in predicting outcomes. So I think we should recognize the limitations of body mass index and not throw the baby out with the bathwater.
I appreciate you saying that, because you're right. BMI is actually really easy. And you can calculate your BMI like right now versus waist circumference. It's hard because where I measure might not be where you measure. And then it's just, so from a research perspective, that would be a nightmare. So I understand that.
I think we have one more question before we finish up. Do you know if pharmaceutical companies plan to expand the access to their diabetes and obesity treatments to developing countries?
Don't know.
The
Oh
special
wait, I did read about part of the push to get an oral formulation is that it will be more affordable in developing countries, and they can market it in developing countries as well.
Is obesity as much of a challenge as it is in the US in other countries? I know that it's increasing in some parts of the world, but are other parts of the world where we are?
No, we're leading for sure.
China's catching up.
Yeah, which is interesting. And some parts of Europe are getting there, but not yet.
And this is just my question. Are there any benefits to the oral medications as opposed to the injectables?
From a weight loss perspective, no. Rybelsus is the only one out right now that's orally FDA approved, and that's the oral form of Ozempic. It's a semaglutide. From what I've seen comparing to injections, it's not the same effect. Again, it's a daily medication, right? So you also, how consistent is a person on it, things like that you have to consider, and the dosing you also have to consider. So from at this point, it's not as, there is a oral tirzepatide, I think that's in the works, so we'll see if that is more effective. But people just don't like needles, so the oral thing would, I think, be helpful.
Do you think having an oral medication could help with a maintenance drug phase or reaching those who are fearful of needles and perhaps closing some of the disparity gaps that we've been talking about? If it's less expensive?
So interesting. I had a conversation today with our rep, and I'm thinking it's not going to be, right now, the numbers I'm seeing is not considerably cheaper. So.
What is it?
Like the same, like
What's not cheaper?
Pills, the pill form.
Oh, but they don't even have. Oh, you mean
Like, right. Yeah. So things like that, like eventually when they do come out, the question is how much cheaper is it? But I do like that idea, like compared to taking an injection, maybe it will become just this, you get to your goal, and maybe you take this pill every day. But where that's going to go and how that's going to fit financially with insurance coverage, we'll wait to see.
Well,
I'm just gonna throw one more thing because it just popped into my head. I'm sitting here watching you all at tables eating, and these drugs are really, it's not just medicine. It's also changing our sociality because people don't really want to eat anymore, right? And they don't want to go out and have a 3-hour dinner because they don't eat 3 hours worth of food. And so people are like, well, let's instead of meeting over food for dinner, let's go for a walk. Let's do these other things. So it really is changing our sociality, the tempo of our lives, and these are, big changes.
Is that a good thing or a bad thing?
Well, I love New York restaurants, so it's a bad thing for me. I already have friends. It's like we can't go out to eat anymore because they don't want to sit there for 3 hours.
It's funny, I have a patient in Staten Island, and he's Italian, and he's on one of these meds, and apparently he's causing conflict in the house because his mom cooks. He's like, I gotta eat her food. I was like, you can't because you're on this medication. He's like, but you don't understand, she's gonna disown me. And so it's funny how, and I was just talking like, I'm Filipina. We have to eat. Like if you don't eat, it's like you're insulting it's disrespectful. So where that falls, I don't know. I always say, like, instead of meeting your friends for drinks, can you meet for a walk? Like, is that a thing? Can you, instead of a birthday dinner, can it be like a birthday run? I don't know. Like, that's not a thing. So we have to sort of change that concept of always meeting over. Now, mind you, I love to eat. That's why I have a weight loss clinic. But I do think we need to sort of change how we relate to food and where food comes into play.
Thank you. I'll pass it on to Dr. Wexler.
We'll have Dr. Wexler back up, but thank you both so much for all
Thank
of
you
your
very much.
insights.
On behalf of the School of Global Public Health and NYU Rory Myers College of Nursing, I'd like to thank all of our panelists for joining us tonight. Thank you, Dr. Chang, Dr. Godwin, and our excellent moderator, Ms. Harrison. Please join me in a round of applause. A lot to think about, probably more questions than answers, but really, really thought-provoking. We hope you enjoyed the lively discussion and networking with colleagues. There still is after a talk on weight loss. I'm going to tell you, there still is a lot of good food, so please help yourself. Get home safe, and we look forward to seeing you at the next event. Thank you, everyone.